We are the Center for Advancing Health Outcomes, research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
My name is Michaela Davies, the Center's Director of Communications. To begin, I would like to acknowledge with gratitude that we are situated on the traditional, ancestral, and unceded homelands of the Coast Salish peoples, and that much of our work takes place across numerous and distinct territories from coast to coast. We are so lucky today to have Dr. Troy Grennan with us. He is the physician lead of the HIV/STI program at the BC Centre for Disease Control and a clinical associate professor in the Department of Medicine at the University of British Columbia. He's an infectious diseases physician and researcher, where both his clinical and research work focus on sexually transmitted infection, treatment, and prevention, HIV, anal cancer screening, and the health of gay, bisexual, and other men who have sex with men. Dr. Grennan holds a Health Professional Investigator Award from Michael Smith Health Research BC, is Vice Chair of the Public Health Agency of Canada's National Advisory Committee on Sexually Transmitted and Bloodborne Infections, and co-lead of the Co-Infection and Related Conditions Core of the CIHR Canadian HIV Trials Network, known to us as the CTN. He is also co-principal investigator of the DISCO study, a Canadian clinical trial examining the use of doxycycline for STI prevention. Thank you so much for joining us today, Troy.
Thank you. All right, thanks everyone, and thanks for the opportunity to speak here. I'm at the awkward stage in my life where I kind of maybe need reading glasses, and I need glasses and contacts for distance. And I'm not used to wearing my glasses because I wear contacts a lot, and so if I look like I'm doing like a lot of weird things with my glasses because I'm struggling to adjust to this new normal. So I apologize if it's distracting. All right, so today I'm going to talk about some of the work that I've been doing for many years, which is focused on looking at the relatively novel use of the antibiotic doxycycline for preventing STIs. So going through this, I'll be going over some of the background for this, including some of the studies that have been done, and then also going through some of the work that I've been co-leading with some folks from across Canada. Okay, let's see. There we go. So I just want to start out and acknowledge that I live, work, and play on the unceded, ancestral, and traditional territories of the Coast Salish peoples, and more specifically the Musqueam, Squamish, and Tsleil-Waututh nations. For my disclosures, I really want to highlight a couple of things. So as was mentioned in my bio, I'm Vice Chair of the Public Health Agency of Canada's National Advisory Committee on STBBI. Obviously, I just want to say, I think it's obvious to everyone that I do not speak on their behalf during this presentation. These are all of my own personal opinions and based on the work that I do and continue to do. So the other key disclosure I want to make is that I will be discussing the off-label use of doxycycline for STI prevention. So it is not an approved indication. When you look at that big product monograph, it's not there listed as an approved indication by Health Canada. But essentially the entire presentation is about the off-label use of doxycycline for STI prevention. In terms of mitigating potential bias, I will be presenting current clinical trial evidence for the use of doxycycline or biomedical prevention strategies as a biomedical prevention strategy for STIs. And I will also be discussing recommendations and statements from various groups as well. Can everyone hear me okay? It's coming through the mic, even though I'm a little bit far. Okay. I'll just present this outline. I won't go through it in detail, but I'll give some background, go through some of our studies, and then talk a little bit about implementation issues, and then a bit on the way forward. So for background, a very short background and a very short rationale why this work is important. And it's all here in this very busy, colorful slide. So really the basis of the rationale for why this work is important is what you see up here. So you have the three most common reportable bacterial STIs, syphilis, chlamydia, and gonorrhea. And what you can see in the box to the right, is that over the course of the last decade, there have been significant increases in all of them. And most specifically, if you look at syphilis, it's been huge, nearly 400% increase in syphilis over the last decade. I would ask you to just ignore this downward trend, which occurred between 2019 to 2020 for all of three of them, because we all know what happened in 2020. And we all also know that during the beginning, especially the beginning and the first sort of half year of the pandemic, that really had an impact on a lot of healthcare access and testing and many different things. And there really was a blip in numbers at that time. And we know that since this time, the upward trend for STIs has increased. The other key piece of the rationale is, in addition to increases in rates, we've also seen increases in complications. So we've seen increases in the number of neurosyphilis cases and ocular syphilis cases. So these, potentially devastating complications that can occur as a result of early infection with some of these bacterial STIs. This has been in the news a lot in mainstream media over the last several years. The concern about gonorrhea being resistant to basically everything that we use to treat it, and such that this has been a World Health Organization priority for global health for several years now, this issue of gonorrhea resistance. And finally, we're also seeing increases, again, this is over a few decades now, the early 2000s, in these sort of more invasive versions, I guess, of some of the more common bacterial STIs. So lymphogranuloma venereum, which is LGV, which is caused by certain serotypes of chlamydia trachomatis, which causes run-of-the-mill chlamydia, but it can also cause, these other serotypes can also cause a more kind of concerning and more invasive disease. So just in terms of setting up why, again, further setting up why this is important, I will just ask the rhetorical question. Do not expect answers to this, and I'll go through some of the answers. So what are some interventions that have been used to prevent HIV and STIs, both currently and over the years? And I'm just listing some of them here. You will all know most of them. So condoms and barrier methods, testing, partner treatment, and education awareness campaigns. There are probably more. But these are all meant really to either prevent infection or to diagnose early, treat early, and prevent onward transmission. So when you think about the methods that have been used as well for HIV prevention, these apply, but then also we think about PrEP or pre-exposure prophylaxis, PEP or post-exposure prophylaxis. In some contexts and in some studies, circumcision has had a role to play. And syndromic or suppressive STI treatment, so reducing the inflammation and disease at certain sites where it may make it easier for things to transmit. And of course, treatment as prevention, so or the U equals U idea, the undetectable equals untransmittable idea. And so if you look at any of these, particularly these on the left side, clearly these still exist, but there's clearly a limit to the impact these can have, because we're seeing the rates still going up. So we need to think out of the box and think about other things that can work to help reduce the burden of STIs that are being seen. In terms of clinical precedent for other ways of thinking, I would point you to PrEP. So pre-exposure prophylaxis for HIV is now standard of care in any individual who is at risk for HIV acquisition. And it really acts as a good clinical precedent for what I'm about to talk about with doxycycline. And then just some more clinical precedents, which I'll just go through. So doxycycline is used for malaria prophylaxis, as are other medications. This other bug called leptospirosis. Doxycycline has also been used as a little bit of evidence for it to prevent leptospirosis in areas where this occurs. It's also used for Lyme disease PEP, post-exposure prophylaxis. And then other antibiotics like azithromycin have been used for preventing COPD or chronic obstructive pulmonary disease exacerbations. And again, Septra or trimethoprim sulfamethoxazole has been used for decades now to prevent pneumocystis pneumonia and toxoplasmosis, usually in the context of HIV. So with all of that, I want to introduce you to doxycycline. So doxycycline is an antibiotic that probably many of you have heard of. It's been around for a really long time, really forever in the world of antibiotics since the 1960s. It's a protein synthesis inhibitor, and its half-life is about just under a day. It's pretty broad spectrum, so gram positives, gram negatives. but really where the money is with it is in the atypical coverage. So it covers Borrelia species, which includes Lyme disease and the organisms that are Lyme similar, Treponema species, which includes the organism responsible for syphilis, leptospirosis already mentioned, mycobacterial infections of some type, so Mycobacterium marinum, and even non-bacterial infections like amoeba. So resistance develops via impacts on influx or efflux, and some ribosomal and genetic reasons as well. We have lots of experience, as I said, sort of collectively. The Royal We have lots of collective experience over the years with doxycycline, so we know it's fairly safe, and we know that the side effects it does have are fairly well described, and we know in many ways how to mitigate some of those. All right, and before I jump into reviewing the studies that kind of act as a foundation for the work that we're currently doing here, I want to just define some of the terms I'll be throwing around a lot. So doxyPrEP, so doxycycline pre-exposure prophylaxis, refers to the use of doxycycline daily for STI prevention. So that's a 100 milligram capsule taken daily to prevent STIs. DoxyPEP, and spoiler alert, there's way more evidence for doxyPEP at this moment than there is for doxyPrEP. You'll see through the studies I go through, is the use of 200 milligrams, so 2 times 100 milligram capsules, two capsules taken after a sexual encounter to prevent an STI. So some general principles around doxyPEP, and you'll see this in the studies that I'm presenting, is generally the sooner you take it, the better is the idea, and definitely it should be taken within 72 hours. So we follow actually the same principle with HIV PEP. So generally the sort of cutoff for time period is 72 hours after an exposure. And you'll see from the studies I present that different studies use different maximum number of doses. So one of the studies uses a daily maximum and the other study uses a weekly maximum. So I'm going to start in Los Angeles. And this is really where this research all started. So in 2015, the first study, at least as far as I know, on doxycycline use for preventing STIs was published. And it was a small study. And at the time, and you know, this was mirrored here in BC as well, the biggest concern was syphilis. Because rates were going up so high, particularly in gay, bisexual, and other men who have sex with men, that's really where a lot of the focus of prevention was. So this was a study specifically looking at syphilis. The inclusion criteria are listed on the side here. So men who have sex with men, living with HIV, with at least 2 syphilis infections since their HIV diagnosis. And you can see here, it's a small study. So this is a pilot study, not really powered for efficacy, but it randomized 30 individuals to one of 2 arms, so 1-to-1, so 15 in each arm. One group got doxyPrEP, so daily doxycycline. The other group was the contingency management group. And what that means is that they got a financial incentive. So they got money for each STI study visit that they came to where they didn't have an STI. So if they came to a study visit and were STI free, they were rewarded with cash. So the other arm didn't get cash, they just got the pills. So that was the comparator group. Interesting use of a control group, but we'll see what the results showed. All right, so really the main result is here, circled or rectangled here in red, and it's for the composite outcome of any STI. So it was really focused on syphilis, but they also did this composite outcome of any STI. So what was the effect of doxycycline in preventing any STI? And when you look at the odds ratio, you can see it right here, it was 0.27, which roughly translates to about a 73% reduction in STIs, any STI, in the group that received doxycycline. And so you can see here, just for statistical significance, the p-value is low and the confidence intervals do not cross 1. So it was a significant finding. When you look at the other outcomes they looked at, so gonorrhea, chlamydia together, or syphilis, you can just quickly look at the p-values or the confidence intervals, you can see it wasn't significant. So really, you know, a promising result. Again, not powered for efficacy, but this promising. Then we jump into some of our work in progress. Actually, this work is now done and we're submitting it for publication. But this was the first study that we did here in BC, in Vancouver, looking at, again, it was doxyPrEP. And this time it's called the DUDES study. So Mark Hull, who works here as an ID doc here, came up with the acronym, so kudos to him for that. Can't take credit. I will take credit for DISCO, but we'll talk about that later. So this was a randomized controlled trial. We enrolled 52 people. So again, not a huge number, really a pilot study. And what we were doing here was we were looking at the use of, so it's the dual daily use of doxycycline and HIV, syphilis and HIV PrEP. So we were looking at folks who were HIV negative, so either MSM or trans women with a history of syphilis in the last 3 years. That was the inclusion criteria. And they were, so all 52 received 1 year or 48 weeks of HIV PrEP with tenofovir emtricitabine, which is the standard medication used. And then but the group was divided into 2 different groups. So they were randomized to one of 2 arms. So the immediate arm got doxyPrEP for the full time as well. So the doxyPrEP and HIV PrEP, 48 weeks. The other arm was the deferred arm, and they got doxyPrEP for 24 weeks, deferred by 24 weeks. So for that first half of the study, they were only on HIV PrEP. They weren't on doxyPrEP. And that was really meant to be used as a comparator between the 2 groups to see how basically the difference between those on doxy and those not. The usual things were done as follow-up, some of which I'll talk about later. And the key findings here are the top bullet, really. So no participants on doxycycline developed syphilis or chlamydia. So just as an aside, for those of you who don't know, doxycycline is a recommended treatment for both syphilis and chlamydia. So either a first-line preferred treatment or an alternate treatment when you look at the guidelines. And it's not a preferred treatment or even usually a considered treatment for gonorrhea for resistance reasons. So not promising, but not a surprising finding. But when we looked at the overall likelihood of developing an STI related to doxycycline use or doxyPrEP use, we did see some promising results similar to the first study I showed you, with an odds ratio of 0.18 or about an 82% reduction in any STI occurring. And that was significant. Again, small numbers, but reassuring, promising data. And then just breaking it down a little bit more by chlamydia and syphilis. So in the deferred arm, in the first 24 weeks, there were 10 cases of chlamydia. So in those not receiving doxycycline, there were 10 cases of chlamydia. And in the group receiving doxycycline, there were no cases. So that was also significant here. And then there was 1 case of syphilis in the entire study, so we can't really comment on that. And it was in the deferred arm. And then gonorrhea, there wasn't a significant difference between the 2 arms, but there was a numerical difference in the 2 arms. That's just not particularly meaningful here, but it will, just keep that in mind because I'll be talking about similar trends later. So in the deferred arm, there were twice as many cases of gonorrhea as there were in the immediate arm. So in those on doxycycline, there was half the number of gonorrhea cases than in those not on doxycycline. But it wasn't significant, as I said. Okay, so just to summarize that really quick. So 2 pilot studies, only one of which is published. One has been presented with a total of 82 participants. So not huge numbers, promising, but really not powered for efficacy. That's kind of the bottom line with doxyPrEP. And there'll be a little bit more data coming shortly. So where we went next was doxyPEP. So doxyPEP, again, post-exposure prophylaxis, post-exposure use of doxycycline for STI prevention. This study was from France. They had 1 site in Montreal, but really it was a French study, and it was a sub-study of the HIV PrEP study IPERGAY, which was the first and one of the only clinical trials looking at the use of event-driven HIV PrEP for HIV prevention. So once that study ended and they rolled into an open label extension, they did a sub-study looking at doxyPEP in some of these individuals. And what they did was they had 232 participants who were enrolled in IPERGAY. And they randomly, in an open label way, randomized them to 2 different groups. One group received doxyPEP. So taking doxy within 72 hours, a maximum of 6 pills per week. So they had a weekly maximum of 3 doses or 6 pills. And then the other group got no doxy. And each group had 116 people. So again, bigger study, not huge, but bigger study than the ones I've previously shown you. And so what you can see here, these Kaplan-Meier curves is just even just looking at the trend, you can see for the overall any STI outcome for chlamydia, for syphilis, there is a difference in the PrEP versus no PEP arm. So the no PEP arm is in red, and you can see this is the y-axis is measuring the cumulative probability of a first STI. So the probability is higher in the no PEP arm for all three of these. So we get a happy face here, but you can see for gonorrhea, there was no difference. And when you actually look at the stats, it wasn't significant. So overall, it seemed to work for the composite outcome. It prevented STIs in the doxy group for the composite outcome, for chlamydia alone, for syphilis alone, but not for gonorrhea. Okay, just keep that in mind. We'll get back to it again. And then the next study, which is the one that has received sort of more recent press, and which is really the one that I feel has driven a lot of the interest in this area over the last several months, was a study that was published in the New England Journal of Medicine earlier this year by an American group led by Annie Lukemeyer from San Francisco. This study was done in both Seattle and San Francisco, and it was called the doxyPEP study. So what they did here was very similar to what the French study did, is they had folks randomized to either doxyPEP or no doxyPEP, but here they did it in a 2-to-1 fashion. So twice the number of people got doxy versus those who didn't. And then they also just broke it down into 2 different cohorts. So they had the folks living with HIV cohort, and they had the folks who were HIV negative but on HIV PrEP cohort. So they just broke it down. They got the same interventions and the same kind of follow-up, but they just broke it down in those 2 cohorts. And this study actually had a maximum of 1 dose per day. So they had a daily, and their rationale for that was just to reduce confusion with participants. Because you can imagine it can be hard to counsel people on how to take something a maximum of 6 times, like 6 pills a week. You know, it would be, so they just decided for simplicity, they would do it this way. And so before I get into the results, I just want to say that this study was stopped early by the Data Safety Monitoring Committee for efficacy. So they said it is no longer, I don't know what words they used, but I will paraphrase, it is no longer ethical to continue this study as is, because doxycycline is too efficacious to not provide it to everyone. So it was stopped early. It was supposed to enroll over 700 people, and it ended up with about 501 people in the final analysis. So this is a primary endpoint. So the incidence of STIs per quarter. So they were seen quarterly study visits, and you can see again, just visually, you can see a clear difference. So this is again just broken down by the PrEP cohort and the folks living with HIV cohort, but you can see a clear difference in the doxy arm versus the no doxy arm, right, for both. Clear difference visually, but also when you look at the stats, you can see that the risk reduction was 0.35, which means doxy overall for everyone, for all 3 STIs, reduced the incidence by about 65%. Then breaking it down by the individual infections, you can see here again, visually, you can see a clear difference in the PEP arm on the left for both cohorts and the no PEP arm on the right. So for all 3 infections, you can see there was a visual difference there. If you want to see what the stats showed, it was significant basically for all groups except for this one group here, but syphilis, there are way fewer syphilis infections in general. So we can expect that that might be a numbers issue. But you can see here, just the trend here is that for chlamydia and syphilis, doxycycline did work in both cohorts to reduce the incidence of STIs by, 87%, 77%, 88%. When you look at gonorrhea, it also worked. It's statistically significant. You can see from the p-value and the confidence intervals, but it was a dampened effect, right? So it worked, but not quite as well as it worked for the other 2. So again, just keep that in mind. We're going to get back to all of this. It's all going to make sense. So, and finally, we're going back to France. Same investigator, updated trial, not yet published, but it has been presented. And it's a bit of a complicated study. I'm not going to get into the details. It was a factorial design where folks were enrolled. So this was MSM on PrEP. So they were enrolled in this study. It was open label where they got doxyPEP or no PEP. And then they also got the meningococcal vaccine, which is also called Bexsero. because it has been sort of noted to potentially have some preventative impact on gonorrhea. I won't get into the vaccine stuff. We're just talking about doxyPEP, but suffice it to say they wanted to enroll 720 people here. And again, it was ended early by the DSMB because of efficacy of doxycycline. So another study ended early because of efficacy of doxycycline. So what this showed was when you look at first chlamydia or syphilis infection, so that was their outcome, time to first infection. You can see again, this is the probability of having an STI in this y-axis. You can see that the no PEP arm had a higher probability of an STI, and it was about 84%. It was about an 84% reduction for doxycycline for either syphilis or chlamydia for a first infection. And then just ignore, so that's a happy face. So just ignore this side of the slide here. This is for mycoplasma. I'm not going to talk about this today, but even for gonorrhea, recall that the first French study didn't show an impact. It was a smaller study, but it didn't show an impact on gonorrhea, but this one did. So you can see here about a 50% reduction. It is significant, and there is a difference between the two groups. So doxycycline did appear to work to prevent gonorrhea as well as syphilis and chlamydia. Okay, so we get a happy face there. Great. Okay, so the last background study I'm going to talk about is this Kenyan study, which was, if you speak to the investigators, these results were very disappointing. So this was done in Kisumu, Kenya. It was 550, I think, roughly, cisgender women attending a clinic where they received HIV PrEP and at risk for STI acquisition as well. So they had a high baseline rate of STIs, bacterial STIs. And if you look at the Kaplan-Meier curves in the bottom here, you can roughly see there wasn't really a difference in the two arms for either any STI or chlamydia. They didn't individually look at gonorrhea because of high resistance rates, and they didn't look at syphilis because there are very few cases of syphilis in this area. So they were really just focusing on either overall or chlamydia. And you can see nothing is significant. So it didn't work. I'll get into why in a second. So overall, we have nearly 1,300 participants, excluding the Kenyan study, but 1,300 MSM and trans women participants, where doxycycline has demonstrated clear efficacy in reducing STIs to a significant degree. So that's kind of the summary. And this is just, I'm not going to go into this. This is just a summary of all of the studies. I generally include this for folks who want to look at it later when they get the slides. So there are a number of, and I'm sure as I've been going through this, if this is something you haven't thought about before, I'm sure there are a number of you who had a bunch of questions come to mind. Hopefully I'll cover some of them here. So I'll go through each of these points one by one with a slide for each. So the first question I want to address is why the differential impact on gonorrhea. So we've seen some conflicting results. The first French study, no impact on gonorrhea. The first US study on doxyPEP, there was an impact. So at that time, at that very moment, before the third French study, the theory was that there are different baseline rates of resistance in the community of gonorrhea to tetracyclines or doxycycline. Tetracyclines is a family of antibiotics. So about 30% in the US baseline resistance versus 60% in France. So maybe this higher baseline rate of resistance is the reason why they didn't see an impact in France. Just for context, in Canada, the rate is likely closer to the French rate. So when you speak to folks at the National Microbiology Lab, they'll say it's about 60% here as well. But what we did see with the latter French study is that even in the context of these very high rates, baseline rates of resistance to tetracyclines, it still seems to have an impact. So that's why it's important to keep this in mind. Again, not that we would ever rely on doxycycline as a medication to treat gonorrhea, especially if we don't have culture results where we can look at to see what it's susceptible to. But this says something, and it's important data to have. And then the other question to ask is, what's the impact, and I'm sure this is the question that most people have, is what's the impact of doxycycline on antimicrobial resistance overall? So when we think about that, we generally think about it, in, at least in this context, in two different ways. So antimicrobial resistance in STI organisms, so we want to know what impact it's going to have on, chlamydia, syphilis, gonorrhea, but also on non-STI organisms, so what we call off-target organisms, things that might just be living in your nose, in other parts of your body, kind of these commensal or just kind of colonizing organisms that we have on our body. So there's really, I think the bulk of the analyses for these are forthcoming. All of the studies that have looked at doxyPEP and all of the studies I've presented have done a lot of work here, and some of it is still kind of not yet analyzed. But so far what we have, there's not very much data yet. The other key thing is that, as I mentioned, doxycycline is a recommended treatment for syphilis and chlamydia, and nowhere in the published literature is there any evidence that there is resistance. There's been no documented resistance in syphilis or chlamydia to doxycycline, which is a good thing. So that's another reason why it would be very important to monitor this. One of the challenges with this is that it's relatively straightforward to monitor for resistance in gonorrhea, because you just slap it on a culture plate, you can do your antimicrobial resistance testing, and then you get an answer. For chlamydia and syphilis, these are not organisms that are easily culturable, in fact, almost impossible to culture, unless you're in a very specialized lab. So there's no way you can really just monitor for resistance. The way we do that in chlamydia and syphilis is through molecular mechanisms, sequencing, and it's still very much very exploratory. So it's hard to really monitor it in an easy way. Reassuringly, our members of our team, including Daryl Tan from Toronto, did a systematic review a few years ago just to look to see what impact and what data was out there on chronic use of tetracyclines on antimicrobial resistance. The data quality was poor. There was some evidence of some increased resistance in respiratory and oral and GI pathogens, but it's hard to comment on it, unfortunately. So in terms of the specifics from the study, so I won't go into too much detail on this, because again, if you even just eyeball the numbers up there, you can see the numbers are very, very small. But what the general trends was, for instance, in gonorrhea, for instance, which, as you may remember me saying, is relatively easy to culture, so we can get generally good AMR data on gonorrhea. About 30% baseline resistance, 27% in the US study, and then sort of in terms of resistance development in the two groups, so those receiving doxy and those not, about 38% to 12%. So higher numerically, but again, really small numbers. And in the doxyvac study, there was just everything was resistant already from the cultures they had at baseline. And then in terms of Staph aureus, so the main off-target organism they used was Staph aureus, usually in the nose or the throat. There was low carriage in the doxyPEP group, so there weren't high rates of carriage, and there was marginally higher rates of resistance that developed over the course of the study, so 5% versus 4%. And similar things were seen in our DUDE study as well. So low rates of carriage, really, really low numbers of resistance, so hard to comment. That was a lot of talking for not a lot of substance, I apologize, but there's just really low numbers, and I assure you the numbers are coming. The other thing I wanted to mention as well is the other thing that comes up a lot is what impact does doxycycline have on the human microbiome? So to most people, including to myself, when I first started reading about this, it's like, what impact, like what is the clinical relevance of the human microbiome? Like, why should we care about it clinically? And the reason is, it has huge implications for many different parts of one's health. So, just to give you some concrete examples, and I know David Patrick from the BC CDC has done some work on this, is, for example, early childhood exposure to antibiotics impact the human microbiome in such a way that, it impacts the development of asthma. It can impact things like obesity, other chronic diseases like diabetes. Other sort of tangible examples are, and just to define it, the human microbiome really just refers to the collection of different microorganisms. So bacteria, fungi, viruses that live in a certain area of the body. So we often talk about like the gut microbiome. So that'll include any part of the gut, including the rectum and the colon. And a lot of work has been done on the vaginal and the cervical microbiome, looking at things including how the composition of the microbiome impacts HIV transmission, or how the composition and the function of the cervical microbiome impacts progression of cervical precancers to cancer. So work has been done in these areas. So what we did in our DUDE study, this is not yet published, and I don't really have any idea how best to interpret this because I don't understand a lot of it. Thankfully, I work with people who do. But the folks who did this study, or who did this work, looked at the microbiome composition, so the populations of different organisms that were living in the gut, and we used rectal samples as an example. And there was no difference in the group receiving doxycycline versus those not receiving doxycycline. So that's reassuring. What does that mean? Don't really know. We'll do more work. So finally, for the, well, not finally, but for this little part, the other question that comes up is what are the implications of these findings on use of doxycycline in other populations? So we already saw that in cisgender women in this clinic in Kenya, it didn't seem to work. Well, in fact, it did not work. And the reason, so the initial study was presented in early 2023, and then the authors presented a follow-up this summer at a different conference. And what it seems like the reason was adherence. So when they looked at, they did doxycycline hair testing. So they took hair samples and then looked for doxycycline. And it looked at about nearly half of the folks who were meant to be on doxycycline didn't have any detectable doxycycline in the hair sample. So that suggests that maybe adherence was an issue. But some of the outstanding questions on this are, how would this work in cisgender women in other contexts, in other countries? Is there a role for maybe enhanced adherence measures in certain populations? And then what's the role of doxyPrEP? So a different way of using doxycycline in some of these other folks. So now I'm going to jump into, for the last little bit, the last few minutes, I'm going to jump into the work that we're doing. And this is kind of future work, but also work that is now started. So it's less of future work and sort of current work. And that's our DISCO study. So DISCO stands for doxycycline as an intervention for STI chemoprophylaxis. And this is a CIHR and CTN funded national multi-center study. We have 6 cities involved, and we're aiming to recruit 560 folks. So the inclusion criteria, which I'll talk about in a sec, are again, very similar and mirror the other studies that I presented. So we're gonna have 2 arms, randomized 1-to-1. One of them is going to be STI or doxyPrEP, so daily doxycycline, and the other arm will be PEP, so post-exposure, 200 milligrams, and we're using the French maximum, so the maximum of 600 milligrams per week. The objectives are really the following. So non-inferiority of STI PrEP versus STI PEP, and so in this scenario, we're really considering STI PEP to be kind of the standard of care, because we want to look at non-inferiority. We're going to look at efficacy. We're going to look at a number of other outcomes, so acceptability, tolerance, adherence. We're doing doxy levels. We're doing a bunch of other things. And then we're doing some modeling studies, which I'll talk about in a second. I also want to point out that this study was very delayed in getting started, primarily because it initially started as a 3-arm study. We had a 3rd arm, which was the standard of care arm, where folks didn't receive doxycycline. And so as we were about to start recruiting in early 2022, the news release from the US study came out indicating that they'd been shut down early. And so in conversation with our study team, steering committee, community advisory board, it was determined that it was no longer ethical to have a standard of care arm. So we ditched it, but the approvals and revisions took a long time. So we are now recruiting as of June. So the eligibility criteria, like I said, mirror a lot of the other studies. So MSM or trans women who are sexually active and intending to remain so, with at least one bacterial STI in the last year. And that's fairly standard across the studies that I presented in terms of inclusion criteria. So we began enrollment at our Vancouver site in mid-June. Calgary is also now recruiting, and Ontario and Quebec will be recruiting just shortly. They're just waiting for final approvals. And in that short period of time, we've already recruited over 50 participants. with our site goal being 200 of the 560. And we have a huge waiting list still. So we're working our way through the waiting list. And that's our website there. So just a little bit of the modeling work. So this is always really interesting because it sort of allows us to comment further on not just the, so, you know, we have the data from the study and the efficacy and all that stuff, but modeling work really uses some of the inputs from our study, but also inputs from external, you know, surveys and that sort of thing to help talk about or predict sort of the broader impact of some of this work. So this work is being led by Sharmista Mishra, who's an ID physician and a mathematical modeler from Toronto. And she's going to be looking at a number of things, including the potential impact of doxyPrEP and PEP. She's focusing mostly on syphilis, but we'll be looking at the other infections, depending on degrees of coverage. She's also going to look at issues around sexual networks and the syphilis epidemic stage, as well as access and coverage to determine whether or not the doxyPrEP and doxyPEP and PrEP will impact the syphilis epidemic. And then we'll also be doing some cost effectiveness work, so looking at costs and population health benefits, depending on coverage and access in different urban centers across Canada. The final study I want to talk about, which is the final little bit of our work in progress, is another study. So this is a sister study to the DUDE study that I mentioned. So the DUDE study is the one that was done in folks who were HIV negative. It's completed now. So the DAD study was the sister study, and it's just about to finish. So we're fully recruited. Again, we recruited 52 people, this time between Vancouver and Toronto. And this was for folks living with HIV. So gbMSM living with HIV, who had a syphilis infection in the last 3 years. Again, similar inclusion criteria. And what we did was, this was, even though it was a pilot study, it was a randomized, double-blind, placebo-controlled trial. So we haven't done any of the unblinding or analysis yet. So we don't actually know what any of the initial results show. But we will have our final participant visit in January. So we should be able to speak more intelligently about this study at that point. So finally, before I stop for questions, I just wanted to briefly mention this study that was very recently published in CID. And it's a study by Michael Traeger, who's did a lot of his sort of, I think, postdoc work in Boston, is now back in Australia, which is where he's from. And he really wanted to look at the impact of doxyPEP on STI incidence using sort of some hypothetical scenarios. So what he did was he used data from a clinic in Boston, looking at just over 10,000 individuals, looking at STI rates and infections and that sort of thing. And then he also used the doxyPEP efficacy estimates from the studies. And he said, okay, if we were to prescribe doxyPEP to these different groups, what would be the impact? And he used this idea of number needed to treat. So how many people do you need to treat to prevent one infection? So so again, just getting back to this slide here. So questions around implementation come up, acceptability. You know, one of the things, and one of the drivers of why doxyPEP has had much more research behind it. And, you know, our study is the first one that will be looking at PrEP versus PEP. Like, no study has done a head-to-head comparison, which I think will hopefully provide important information. But one of the reasons behind why doxyPEP has been looked at more, I think, is there's been generally an assumption that doxyPEP is preferable because in general it's going to lead to less antibiotic exposure. People are going to be taking it just when they need it. And then maybe that would translate into patient preference as well. So patients would prefer to take it that way. But actually, when you talk to people, and we've had many conversations with folks, including our community advisory board and other folks, some people say, you know, I'd much rather take it daily. So I'd much rather take PrEP because I take these other medications daily. You know, some people take HIV PrEP daily. Some people take HIV medications daily. So like, it's just easier to remember. I don't need to plan, you know, so it's just easier. So I think we've made some assumptions over the years that maybe we need to kind of rethink. in terms of guidelines, if you look for guidelines around doxyPEP or doxyPrEP use, you won't find many. Some local places like the San Francisco Public Health, you can see it up here on the slide, has put out some guidelines. Seattle King County has recently put out some guidelines. And there's a position statement here that I included, but it's actually been updated since in the last couple of weeks, where Australia, New Zealand, it's called ASHM, so it's like the national STI organization, have put out guidelines as well on the use of doxyPEP, really focused more on syphilis actually. So those are coming, I think, and will help guide how we use it. And I think with that, I will end and take questions.